Good afternoon, everyone. On behalf of the Registered Nurses Association of Ontario, I want to welcome you all to today's webinar, In the Know with RNAO, Integrating Tobacco Interventions into Daily Practice Best Practice Guideline. My name is Sheila John, and I am a Program Manager for the Mental Health and Addiction Tobacco Initiative. I was also a part of the guideline development process, and I will be one of your presenters for today, along with my two wonderful colleagues, Shelly and Jennifer Bouwmeester. Just before we get started, I have some housekeeping issues to address. You will need to have your speakers up in order to hear this webinar. Also, the presentation will be recorded and will be available after this webinar on the Tobacco-Free RNAO website. If you have any questions during the webinar, please feel free to use the chat box. We will be dedicating the last 15 minutes to questions. If we don't have enough time at the end, we will be able to submit responses to you in writing. So I do want to take some time to introduce our presenters for today. Joining me today is Jennifer Bouwmeester, who is a public health nurse at the Tobacco-Free Living Program at Simcoe Muskoka District Health Unit. Jennifer was also involved in the RNAO Smoking Cessation Initiative and was a coordinator from 2012 to 2015. She practices in the area of comprehensive tobacco control, including prevention, protection, and cessation since 2006. To the right is Shelly. Shelly is a primary healthcare nurse practitioner at the Stone Gate Community Health Center. She has a nursing diploma from the Osler School of Nursing in Toronto and a BScN and PHC NP certificate from York University, a Master's of Science, and a PhD from the University of Toronto. So welcome to Shelly and Jennifer. Just to review some of the objectives for today, we will be reviewing the guideline development process. We will be identifying some of the new and revised recommendations. We will be discussing the evidence that supports the recommendations and reviewing some of the new tools and resources that are available in the new guideline. And we'll also be taking some time to discuss the steps that the expert panel took to make some key decisions. I also want to take some time to acknowledge our stakeholders. We had around 35 stakeholders that provided feedback and input to the guidelines, so thank you very much. I can see some of you are online with us today. I want to thank the RNAO project team and the expert panel. I also want to take some time to acknowledge and thank our three endorsers, the Center for Addiction and Mental Health, the Canadian Cancer Society, and the Ottawa Heart Institute. We really want to appreciate your ongoing support and thank you for your endorsement letters. You will be able to read the endorsement letters in the final copy of the guideline. Just to review a few terms before we get started, the term client will be used throughout this webinar and also be addressed in the guideline, and that is to encompass both the patient, the person, but the term that we decided to use was client, but it is all-encompassing. The next is smoking cessation versus tobacco interventions. There was much discussion with the panel about what we would be using in terms of the topics covered in the guideline. After much discussion, it was decided the scope would include all forms of commercial tobacco and not be limited to smoking alone. So this would include cigars, cigarillos, chewing tobacco, dissolvables, pipes, and snuff. Thus, this is why the guideline's name changed from smoking cessation to tobacco interventions. The next is tobacco and nicotine. So we'll talk a little bit about the process, and once our draft guideline was sent out, it was actually entitled Integrating Tobacco and Nicotine Interventions. This was raised by some stakeholders that it was important not to focus on nicotine, although it is the addictive component of cigarette, but look at nicotine as a positive aspect because of the nicotine replacement therapy. So we did end up dropping the nicotine, and the title ended up being Integrating Tobacco Interventions into Daily Practice. And we will be going over the purpose and scope of the guideline and the levels of evidence. So I'm excited to say that today is the actual date we'll be launching the new guideline, the 3rd edition of the guideline. We will be sending a link at the end of the chat so you can go directly online and access the guideline that will be uploaded shortly onto our RNAO website. So we're very excited about that. In terms of our guiding principles, these are guiding principles. There's a list that will be found in the beginning of the guideline, and this is to be keeping in mind and having that lens regardless of which population you're working with, which client and what setting you are working in. This will guide your interactions with individuals and impact the care that you provide. So we won't be going over all the guiding principles, but I did want to touch on a few. So one of them is that regular tobacco use is an addiction that requires treatment, support, and repeated interventions for clients. Secondly, nurses at all points of care have an ethical and professional responsibility to provide access to evidence-based best practice treatment and support to clients who use tobacco. Thirdly, clients have the right to access tobacco intervention treatment to support withdrawal symptoms and addiction management in any healthcare sector at all points of care. Also, tobacco users may relapse several times before achieving abstinence, and nurses need to re-engage clients in the tobacco intervention process. There is also an appendice that focuses on the strategies to avoid relapse. If you are familiar with the 2007 guideline, you will see that some of the recommendations have been moved to the guiding principles, so we continue to have this lens. Here's just a few more. I won't go into detail about this. These will all be listed in the guideline. So in terms of the guideline development process, just to give you an idea of what goes into our process, it starts with topic selection. Now this was a revision, so we knew that we were going to be addressing tobacco interventions. The next is we invite a panel of experts to join us to be a part of the guideline process. In total, we had 11 panel members that joined us from different provinces across Canada. We had representation from academic institutions, from public health, from community, and a lot of our partners under the Smoke-Free Ontario partners under the ministry, they also were involved. Thirdly, there was a systematic review process. This is quite a rigorous process that involves 2 RNAO nursing research associates. And this is the point where we look and review and analyze all of the literature that's available on tobacco. This is a 6-month process in total. The next is recommendation development, where we bring together the panel members and they develop the recommendations based on the evidence that the NRAs, the Nursing Research Associates, have put together. After that, we have a first draft of our guideline that is sent out to stakeholder review. And as I mentioned, we had 35 individuals participate in the stakeholder review. The next is editing and publication before the final print. I want to take this opportunity to acknowledge our 2 co-chairs, Dr. Peter Selby and Dr. Shelly Walkerly, who provided a lot of leadership and support throughout the entire guideline process. So thank you to both Peter and Shelly. I also wanted to put this picture in. It is a picture of our entire panel of experts, and as I mentioned before, it included a variety of individuals from different locations representing different sectors and different Smoke-Free Ontario partners. Just to look a little closer into the systematic review process, there were 7 databases that were reviewed in total from 2006 to 2015. The first scan of literature involved over 58,000 articles that were screened. The next was the relevance review and quality appraisal, which was now 923 articles. And then finally, the data extraction and the articles that were actually used in the guideline, which was 85. So this gives you an idea of the amount and rigorous process and the amount of literature that is put into developing this one document. So in all of our best practice guidelines, there are 3 types of recommendations available. There are practice recommendations, which is what the nurses need to know. There's education recommendations, which is what the nurses need to do. And there's system organization and policy recommendations. In this particular guideline, there are 5 recommendations related to practice. You will also notice that these recommendations follow the nursing process. There are 2 recommendations related to education, and there's 4 recommendations related to system, organization, and policy. For the stakeholder review, invitations were sent out, and this is an opportunity for any individual of the community to participate in the guideline development process. We also posted the opportunity on the website for individuals to sign up. There are 35 that signed up to be a stakeholder, so thank you to all those individuals. And we had a variety of nurses from different sectors and different locations involved. You will notice in our guideline, there are 3 symbols that you can see. There's a check mark, a plus sign, and a new symbol. These will be listed beside every recommendation in this webinar and also in the guideline. The check mark indicates that there was no change made to the recommendation as a result of the systematic review. So this means that the recommendation from the 2007 guideline was put directly into the current guideline. There's the plus sign, which means the recommendation and supporting evidence were updated following the systematic review. And then there's the new symbol. That means it's a brand new recommendation that was developed through the systematic review. You will notice that in this guideline, there are only revised recommendations and new recommendations. So it really is a brand new guideline. There has been no recommendations that have been taken from the previous version. So that gives you a little bit of a background on how the guideline development process was. I'm going to now turn things over to Jennifer Bouwmeester, who will be reviewing some of the practice recommendations with us.
Thanks, Sheila. So I'm going to talk to you about the practice recommendations in the guideline. The practice recommendations, as everyone knows, are directed primarily to nurses and other healthcare providers in organizations, but are also relevant to the interprofessional team within the organization, both in acute care, long-term care, and home care within the health system, and in the community. So we're going to look at primary care and public health. And there is application for all of the practice recommendations to the entire healthcare system. The first recommendation has been updated from the original guidelines. So as you can see, the original recommendations was that nurses would implement minimal tobacco use intervention at all clients and at all points of care. And the previous recommendation was the 4 A's, so the ask, advise, assist, arrange. The most common question during our process, one of the most common questions during the process as we were reviewing the document over the past few years was, how many A's are going to be included? Well, we can really easily answer that question as the new recommendation states that the assessment piece will include brief interventions to screen all clients for all forms of tobacco use and initiate intervention as appropriate, and will not focus on a specific A. The use of the A's can be 3 A's, 4 A's, or 5 A's, It doesn't matter which brief clinical intervention we are using, as long as we're using one. Brief intervention should be done at every healthcare encounter and should require less than 3 minutes to perform. And it will, the likelihood of success, increase the likelihood of success and increase the amount of time a client remains tobacco-free. So really that does answer the question around the number of A's for you. And as you can see, the A's are, as they say, as they show in this slide, a 3A's approach, ask, advise, assist, a 4A's approach, which was the past recommended RNAO approach, ask, advise, assist, arrange, and then of course the 5A's, which would include the assess piece. So as long as we're using a brief clinical intervention of some sort or a brief contact intervention, no number of A's has been proven to be more effective than another. The important thing is that some type of intervention is used with every client that interacts with the healthcare system. In order to support that brief clinical intervention, the guideline includes a brief intervention flow chart, which I'll show you here and is included in the guideline. So this brief intervention flow chart will walk you through the steps when speaking to clients about their tobacco use. You're going to notice that there's a lot of information on this chart, and that's because we took into consideration those different clinical, inpatient, and community settings that you would be using in any kind of, the type or number of A's that you chose in your organization. And that's going to be really organization and time driven, whichever type of brief clinical intervention you select. So when we look at this flow chart, and I'll just walk you through it quickly, it does look at your initial A, your ask. So you're going to ask every client about your tobacco use at every healthcare visit. Basically, that's going to look like, have you used any form of tobacco in the last 30 days? So the same question we've always been asking, regardless of the number of A's, and that's to determine tobacco use status. You can also determine stage of change from there. And then, of course, we're going to provide our advised statement relevant to the client and the clinical situation that we're in. We're going to ask about readiness to change or determine stage of change. What is the goal in the clinical situation or the community situation that we're in? Are we quitting, are we reducing, or are we managing withdrawal? How does that look for that client? And then we'll go on to provide the most appropriate type of intervention. And of course, if the client is not ready for support, then no other intervention is going to be required other than the advised statement related to the fact that resources are available when that client is interested. And if that client is ready, then we have an obligation to either refer for ongoing support or provide an intervention that's appropriate to the client or the setting. And this chart will walk you through that. And as we look at the next slide, it provides a simple case study about how to use that chart, which I'm sure isn't going to be new information for a lot of people. And if we went back to, so we talk about Joe, he's admitted to hospital. This is a common scenario. He does use tobacco, pack a day. Hospital's 100% smoke-free, and Joe can't leave. How are we going to support Joe? So in a hospital environment, our focus is going to be on using our flow chart or a brief clinical intervention to assess his tobacco use status, determine whether or not he's ready to make a quit attempt, but either way, we have an obligation to support symptom management for withdrawal. And we can use that flow chart, the flow chart, to guide us through that. So continue to identify our goal in this situation is going to be to manage withdrawal. We're going to provide the most appropriate type of pharmacotherapy in order to do that, and whatever resources and supports that Joe needs. And the chart is pretty simple to work through in that situation. When we get to the bottom, it gives you the example of using inpatient counseling, advocating for NRT to be prescribed, and then in a community setting, we're going to offer the resources around quitting and advise the client to follow up with any quit line services or any other available community supports that are appropriate for the client. Slides aren't changing very quickly, sorry. Our next recommendation, 2.0, when it comes to the planning part of our intervention, we need to focus on developing a person-centered tobacco intervention plan with the client. So the previous recommendation was nurses will implement smoking cessation interventions, paying particular attention to gender, ethnicity, and age-related issues, and tailor strategies to the diverse needs of populations. We had significant discussion during the course of the guideline revision process around priority populations, around what priority issues were, and really came to the conclusion that as long as we went into every client interaction with the intention of really developing a person-centered tobacco intervention plan that was focused on the needs of the client, potentially, or with the goal of, essentially with the goal of harm reduction, recognizing social determinants of health, a person's ability to quit, age, gender, lived experience, culture, education, and knowing that those things can impact behaviors, lifestyle choices, and interactions, that person-centered piece was what was most important. The intervention plan should consider the content of the client's individual needs. And if we're focusing on harm reduction, and we should always have a initial priority of harm reduction, cessation being a long-term goal, harm reduction, any program or policy that's designed to reduce drug-related harm, we need to go in with that focus. Healthcare providers can consider asking the clients about what tobacco use means to them, positive and negatives about using tobacco, any small steps they can start making today to start reducing tobacco use and or reducing your children's or family members' exposure to second and third-hand smoke. So using that person-centered approach and taking harm reduction into consideration. And if I can get the slide to change, there we go. The next recommendation moves us to implementation. So we've determined tobacco use status. We've come into the situation with a client-centered approach to make a plan, and now we're going to implement that plan. So the recommendation previously was nurses will introduce intensive smoking cessation intervention when their knowledge and time enabled them to engage in a more intensive counseling. The new recommendation reads, provide clients with or refer them to intensive interventions and counseling on the use of pharmacotherapy if they use tobacco and express an interest in reducing or quitting their tobacco use. Intensive interventions are more than 10 minutes. We recognize that not all nurses or members of the interdisciplinary team have time to provide, or the expertise to provide that type of 10-minute or longer tobacco cessation intervention. So ensuring that you're aware of where to refer your clients to or where they can get that type of counseling and support is super important. The intensive intervention will include an assessment of motivation to quit, identification of high-risk situations and triggers, and discussion of problem-solving strategies to manage high-risk situations. When it's not feasible or possible for the healthcare provider to provide the intensive intervention, that's when we need to know where those resources are available to in the community, be aware of the supports that Smokers Helpline can provide in order to make those most appropriate referrals. There's a variety of tools, many of them are referenced in the appendices in the guideline that will support that move towards a more intensive intervention, and they include providing using the Fagerstrom test for nicotine dependence alongside motivational interviewing techniques, and we are going to talk a little bit about that. So the intensive interventions can include behavioral interventions, recommendations and discussions around nicotine replacement therapy and other pharmacotherapy options. And the guideline does talk about, but recommends use with caution, other guideline or other interventions, including e-cigarettes or vaping, hypnotherapy, laser therapy, electrostimulation, acupressure, or acupuncture. So we say use with caution when it comes to those last few pieces, and it talks about the lack of really solid evidence around the use of those particular interventions, recognizing that the first three listed there are the sort of first-line evidence-informed interventions for smoking cessation. Healthcare providers should have the knowledge around the pharmacotherapy options available, and if they don't, should certainly consider consulting with a nurse practitioner, pharmacist, or physician to determine how best to incorporate those options for clients. With the pharmacological management, nurses should ensure that the pharmacotherapy options are considered in management planning and that clients have access to the appropriate medications and that the medications are administered safely. .2 in the implementation section speaks to treating or referring all pregnant or postpartum women at every encounter for intensive behavioral counseling for tobacco harm reduction, cessation, and relapse prevention in conjunction with nicotine replacement therapy on a case-by-case basis. The previous recommendation read, nurses will implement wherever possible intensive intervention with women who are pregnant and postpartum. So you'll see we have enhanced this recommendation to be more explicit in the use of nicotine replacement therapy. More women who stop using tobacco during pregnancy, or more women will stop using tobacco during pregnancy than any other time in their lives. But we know that due to stress of newborn care, depression, financial insecurity, a lot of women, a significant percentage of women will relapse postpartum within the first year, and in many cases back to the baseline level of smoking or higher. Health professionals need to emphasize that the benefits of harm reduction or cessation for the woman and her fetus are paramount. In addition, when safe for the woman, a healthcare provider should collaborate with the primary care provider to talk about pharmacotherapy and recommend the use of nicotine replacement therapy specifically with women during the pregnancy and during breastfeeding. Women or healthcare providers should also collaborate with the woman's partner and household members to develop awareness about the impacts of tobacco use and be encouraged to reduce use if safe to do so. So really ensuring that we're taking a trauma-informed approach and a safety approach to addressing situations in the woman's home. It really is fundamental to recognize that the health impacts of tobacco use on pregnancy and the fetus are significant, include risk of abruptio placentae, miscarriage, low birth weight, preterm birth, stillbirth, and neonatal death. Infants and children exposed to secondhand and thirdhand smoke are at a higher risk of developing bronchitis, pneumonia, and otitis media. So we can't reinforce enough the importance of providing comprehensive treatment to women on a case-by-case basis based on what's most important to them during pregnancy. And of course, we talked about those methods that are relevant in the context of intensive interventions and behavioral interventions specifically. So the fundamental behavioral intervention strategy that we recommend and that the guideline references to move people through the stages of change and to support people in getting to a place where they're ready to quit smoking is motivational interviewing. I'm not going to talk, for the sake of time, in explicit detail about MI. The information is on the slides and the information is in the guideline. We will just say that motivational interviewing is that person-centered counseling style that really focuses on addressing ambivalence to change and supports people in moving through the stages of change. The basic principles of motivational interviewing are expressing empathy, developing discrepancy, and rolling with resistance, and of course supporting self-efficacy. When we express empathy, we need to create a therapeutic relationship, a positive therapeutic nurse-client relationship, ensure the client understands and knows that you understand their feelings, that you're on their side, and that you have that accepting approach towards all of their situations. You're non-judgmental. Developing discrepancy, we're going to encourage the client to explore the pros and cons of both quitting and continuing to smoke and determine how their current behavior fits with their long-term goals. Rolling with resistance is all about ambivalence and the resistance to change and that being a normal part of everyday life. We can't challenge, we don't want to argue. We want to use resistance as an opportunity to create further discrepancy in the current behavior, show empathy, reflect back the statements in a way that shows understanding, and use this as an opportunity to explore underlying issues. And of course, we're always going to be supporting client self-efficacy, reminding them that they've got the power to make the changes, explore their strengths and motivation and confidence, and provide them with the information and support that encourages them to see their future smoke-free. Those specific skills for motivational interviewing, of course, are the ORs. We can remember through ORs are open-ended questions, affirmations, reflective listening, and summarizing. Open-ended questions will help us to elicit the information that we need to support the client in becoming smoke-free, and will provide us with an opportunity to really hear what the client wants to say and has to say, and how they're feeling about the current situation that they're in. Our affirmations really are about support for what the client is saying, and they should occur frequently throughout all conversations. The health professional in this situation will really recognize and comment on the client's strengths, abilities, good intentions, and efforts. Reflective listening is a foundational skill in motivational interviewing, and is as simple as, I hear what you're saying, I know you're feeling sad. Or it can be more complex. It sounds like you're concerned about what smoking all these years may have done to your overall health. This is really about hearing what the client says and being able to reflect that back. And summarizing, of course, is going to be about pulling the information together so the client can reflect on it. And those can be simpler, complex summaries, really just repeating back your understanding of what the client has to say, so that they can either correct you or they can verify that information and provide more, really to support that therapeutic relationship and help the client feel comfortable that you're really truly hearing them. So that's all we'll talk about around motivational interviewing, recognizing that it's a fundamental practice to support clients in an intensive intervention situation. 4.1 is the new practice recommendation, and this is around evaluation. And there was a fair amount of conversation during the revision process around evaluation and what does that look like for smoking cessation? How do we measure success? And really what the nitty-gritty of this is that we need to evaluate the effectiveness of the intervention plan until the client's goals are met. So this evaluation plan needs to be evergreen. It needs to continue to evolve and change as we provide support and guidance to the client, and as we really move through the quit process. It allows the healthcare provider to assess client engagement and motivation, as well as the client's progress towards achieving their treatment goals. The goals need to be established during the first encounter with the client, but then reevaluated, like I said, at each encounter. They could be, the goals might be cessation, they might be reduction, it might very well just be management of withdrawal symptoms if we're talking about that sort of forced abstinence situation in an inpatient hospital, for example. Establishing the client goals and creating an intervention plan are essential when working with clients who use tobacco. The evaluation stage should be used to review and revise the existing plan and strategies, and may help to address relapse prevention so that clients are well equipped when the triggers present themselves. We might want to, when we're evaluating in an ongoing way, we want to look at number of cigarettes smoked daily, triggers and cravings, withdrawal symptoms, slips or relapses, motivation levels, challenges and success, and give credit to the fact that these things change ongoing. And from visit to visit, we're really going to need to reassess and reevaluate these things and consider how these fit into the client's long-term goals. We want to emphasize to the client that relapses are not indicative of failure as part of that evaluation process. We need to normalize slips and relapses in the discussions around quit planning. Clients need to know that a slip is a slip and it's just a learning opportunity during the quit plan. A relapse potentially is something that that will take them back in the stage of change. That needs to be part of the ongoing evaluation, and the ongoing evaluation should also include sort of an ongoing assessment of that stage of change, and using each of those slips and relapses as discussion points for learning and building a stronger, more solid quit plan to support them in reaching their long-term goals of cessation. And that's it for me. So that is the practice recommendations in the guidelines.
Great. Thank you, Jennifer, for reviewing that with us. That was great. I'm going to turn things over to Shelly now, who will be reviewing the education and policy recommendations with us.
Thanks, Sheila. Thanks so much. And thanks to Jennifer. So the other two pieces of the document, as Sheila has indicated, will be recommendations around education and around systems and policy issues. The education recommendations begin with a general statement about incorporating evidence-based content on tobacco interventions into healthcare professional education programs. The previous guidelines stated that all nursing programs should include content about tobacco use, associated health risks, and smoking cessation interventions as core content. So there's not a great deal of change there. I think the important thing in this new recommendation is that we want to make a strong statement, and this was, we had a lot of conversation about this at the committee level about the fact that we really need to incorporate this kind of education at all levels of nursing education, undergraduates, graduate students, RPNs, RNs, and in the NP program as well. We want to integrate tobacco curriculum into all the various stages of nursing education. We want to make sure that nursing students have the skills and are taught the skills and have the opportunity to practice the skills to support tobacco cessation or harm reduction. It's analogous to the fact that we provide skills, education, and opportunities to practice for a variety of tasks and skills in nursing education, blood pressures, doing a bath, changing a bed, giving medication. It was our feeling that we ought to do the same around smoking cessation and tobacco interventions. Doesn't want to. There we go. The next recommendation is a new one, and we had a lot of conversation about this and actually found a lot of support in the literature around the benefits of ensuring that the faculty who teach tobacco intervention curriculum in nursing education actually have some training in that themselves. This is very new, and we haven't seen this type of recommendation in other guidelines. But we really felt it was important based on what we had found in our very extensive review of the literature. The teaching is better when the people who are teaching it have had some training and or experience themselves. There are a number, and at the end of the document, there's appendices that includes a list of the training and resources that are available to individuals to ensure that they have the knowledge and skills necessary to teach tobacco intervention curriculums. And this, again, would be at any level, whether we're talking about nursing education in community colleges or at the university level. This recommendation is that all the faculty who are involved in that education should have an opportunity to have training themselves so that it improves the quality of the education they're providing to students. So those are the two education ones, and now we have some systems, organization, and policy recommendations. The first, and this augments the original or the guidelines from 2007. This recommendation is that nurses advocate with policymakers at all levels of government for comprehensive smoke and vape-free legislation and enforcement in the community. In the 2007 guidelines, the statements were similar. The first one being that nurses ought to seek opportunities to be actively involved in advocating for effective smoking cessation services, including stop smoking medications. And I think, if we look at the landscape and the environment of tobacco intervention currently, I think we could say that nurses have been successful in achieving that recommendation from the 2007 guidelines. We've seen much more advocacy being done by nurses. The availability of stop smoking medication, NRT, and other medications for patients is vastly better than it was in 2007. And nurses are much more knowledgeable about how to use those. The other recommendation from 2007 was that nurses seek opportunities to be actively involved in advocating for smoke-free spaces and protection against secondhand smoke. And we've got great evidence over the last many years, the last 10 at least, that nurses have been very involved in developing programs such as the Ottawa model for smoking. So this, I think we've seen success from the previous recommendations, and this on top of the research that we looked at in guideline development, helped us to make this new enhanced recommendation for advocacy. We're moving to smoke-free environments. Nurses have been advocates for that and continue to be. We have successfully made, smoke-free environments in hospitals and healthcare facilities. We need to continue to do that in other public spaces for the safety and health benefits of all. If we've encouraged RNs and other healthcare providers to speak to their MPPs, to take action on RNAO action alerts, to get involved at policy levels, and to capitalize on numbers to make a difference in terms of tobacco interventions. Want to put pressure on the government that can lead to change, and we want to make sure that this includes vape-free environments as well. Always applying the same strategies that we used for tobacco intervention to vaping, which is a new way of using tobacco and often has many of the same health concerns. Another enhanced around implementation. So implement and enforce comprehensive tobacco-free policies in all healthcare delivery settings and with all clients, including inpatients and outpatients, as well as with permanent and contract staff. So this is, for me, speaks to the no wrong door approach to tobacco interventions, that everyone that a person encounters in a healthcare facility, and that would certainly mean all the nursing staff, are able to provide them with support around smoking cessation and harm reduction in terms of their tobacco use. The previous guidelines recommended that nurses seek opportunities to be actively involved in advocating for effective smoke cessation services. These are much the same as the last, but it's, I think that was the same as the other. Sorry. Next. This is a new one, and very much based on research. And this is recommendation asks us to embed tobacco use prompts in healthcare records and documentation to facilitate addressing tobacco interventions during healthcare visits. We have good evidence going back actually to the last couple of decades that when we provide prompts on health records, the first thing that happens is that healthcare professionals are more likely to engage patients or clients in the discussion about their tobacco use. We also know that when we engage people in a conversation about their tobacco use and invite them to participate in discussions around the health benefits, that people are more likely to quit using the product or to at least adopt harm reduction strategies. So it's an important recommendation on both fronts. When these sorts of recommendations were starting to be seen in the research some years ago, it was a little harder to do because we were using paper charts. In our current electronic environment, embedding these tobacco use prompts is considerably easier and should be something that nursing staff are advocating for in all of our all of our practice settings. And next, another new one. It seems straightforward enough to recommend that we evaluate tobacco intervention programs and services, but we actually haven't always done very much of that, and we know that that's a very important part of the process of developing and delivering tobacco intervention programs. This is advocating for ongoing analysis of the programs and services. An evaluation plan needs to be developed prior to program implementation. This is a recommendation from the National Centers for Chronic Disease Prevention and Health Promotion in 2011. Facilitators and barriers should be identified and monitored. This is, things change in our environment, and we need to be consistent about assessing where things are successful and where they're not, and why some of the reasons are for those outcomes. The structural evaluation should capture whether or not the organization possesses the resources required to support a cessation program. Examples can include adequate staffing, a budget to provide free nicotine replacement service, and ongoing education for healthcare professionals. Process evaluation looks at the process of providing care, intervention, or education. Examples include assessing whether clients are offered brief interventions or if all clients were provided with information and nicotine replacement. Outcome evaluations may focus on assessing client quit rates, reduction rates, or decline in clients' nicotine withdrawal symptoms. It's an important one from the inpatient side. It's important to determine how the evaluation data will be collected, how the tools, what evaluation tools will be used to facilitate data collection, whether you're going to do surveys or use other tools. And again, that's a resource issue that needs to be explicit in the organizational plan. Evaluation data can be used to demonstrate the impact of an intervention or whether changes are required, which is an important part of any development. Indicators for evaluating and monitoring to measure performance and track impact are also featured in this guideline, so there will be resources for you to use. And I think at this point, then this is the final slide in my section here, is just a review of what we just talked about in terms of evaluation of programs. And this is a useful table for describing the structure, process, and outcome indicators and ways that that information might be gathered and reported when you're evaluating a program. I'm going to turn it back to Sheila now.
Great. Thank you so much, Shelly, for walking us through the education and policy recommendations. It was helpful to see the rationale of why certain decisions were made as well. So thank you for that portion of the presentation. Before I move on to the appendices and tools, just a reminder for all those on the line that if you have any questions for us, if you could please type them in the chat box. We will be dedicating the last few minutes of the webinar to answering any of your questions. So feel free to type in any of your comments or questions in the chat box. I'll be quickly reviewing the appendices. There's a number of new tools and resources that will be featured in this new guideline. One is the appendice for harms from tobacco. Now, we all know that tobacco causes disease and disability to almost every organ, so this appendice is a great teaching tool, whether you're working with clients or wanting that education yourself, to understand specifically the harms that are caused throughout the body. And so this specific appendice is 2 pages and provides a little bit of a narrative of how that particular part of the body is impacted. Another one of our appendices is the benefits of quitting. So this was in our last guideline, but we did revise it and update it to indicate the different time frames and the areas of what happens within those time frames, from 20 minutes to having a better blood pressure, to 8 hours, to 2 weeks having better circulation. So we've included that as appendices as well. Some of the other appendices we've included are a tobacco intervention resource list. So if you're looking for additional resources in Ontario, you can access that resource list. We also talked about, in one of the education recommendations, Shelly recommended that educators be trained in tobacco interventions. So we have included a list of training programs for healthcare providers in the appendices. So if you're looking to be a little bit more skilled and have that extra education before teaching the area of tobacco interventions, whether it be in the clinical or academic setting, please refer to that. That will be a very helpful tool for you. There's a lot of talk about nicotine replacement therapy in the guideline. So there's an appendice also on nicotine replacement therapy and an algorithm that you can follow when deciding on what nicotine replacement therapy is most suitable for your client. We also have an appendice on strategies to avoiding relapse. And we also included the phagrosome test for nicotine dependence, which was also in our original guideline. So this is just a list of the benefits of quitting. This is a part of that human body I had showed you on the previous slide, and just a little bit of the descriptions. Now to go to RNAO resources. Before we talk about the e-learning resources, there is an opportunity for our tobacco initiative and for individuals to get involved. As you know, as most of you should know, the RNAO Tobacco Initiative is based on the guideline. And so this year we're actually accepting 6 more healthcare organizations to partner with RNAO to become an implementation site. So if you are interested in becoming an implementation site, there is an opportunity for you to apply. You will be receiving up to $5,000 that you can put towards implementation activities. You will receive a free workshop in your area, and you will also receive support from a tobacco intervention specialist as well. The RFP for implementation sites will be going online this week. So please, if you are interested, contact us if you have any questions. This is a great opportunity if you're looking at the guideline for the first time and you want some extra resources and support to implement it in your program. So just wanted to give that plug for our program. Now for e-learning. So we have 5 e-learning modules currently online, and these are free, available to anybody. You don't have to be an RNAO member to access them, and they take about an hour in length to complete each. We will have a brand new e-learn that will be coming out in the next month or so on the new 3rd edition of the guidelines. So if you've had previously completed the Helping Clients Quit Smoking, I do encourage you to look out for the new e-learn, which will be based on the 3rd edition of this guideline. We are also working on a tobacco use and cessation for youth and young adults e-learn, and that will be coming out later in the year. So just keep an eye out for all of those resources that are available. Other resources that are available for healthcare providers, we have the Nursing Faculty Education Guide, as we have been stressing the importance of healthcare providers to be skilled and to have tobacco intervention content in the nursing curriculum and health professional curriculum. The Nursing Faculty Education Guide does just that. It helps faculty members and educators incorporate tobacco intervention best practices inside the curriculum. So that's a great resource. The Pocket Guide is one of our popular resources, and it's a real summary of the practice recommendations from the guideline, and that will be updated as well to reflect the new guideline. And of course, the toolkit for implementation of best practice guidelines. If you've joined any of our champion workshops, you'll hear all about the toolkit, which is basically a guide on how to implement guidelines. So many individuals and organizations have found that very helpful. So if you're looking at this guideline for the first time and you need help in how to integrate it into your organization, I invite you to join our champion workshops and look through this toolkit, which is available online to download for free. We also have some women-centered care resources that are available. We have them, all the pictures up on this. Tips for pregnant women and new moms. We have a brochure on stigma and trauma, and we have some posters with different individuals in different scenarios. You can request to have these. These are for free. All we ask is for shipping costs. So any of the resources that I've talked about today are free of charge. Just wanted to identify some other online resources that are available. Some of our partners are listed here: Smokers Helpline, KMH, the STOP program, the Mother Risk program, and the You Can Make It Happen. So these are all resources available to you. As I mentioned previously, the Nursing Faculty Education Guide, and so I won't go into much detail about that. So those are all of our resources for RNAO. I want to thank everyone for joining us today, and I want to specifically thank Shelly and Jennifer for being our guest speakers today. And you're not really guests because you've been a part of this whole process since the very beginning. So thank you for your contributions in presenting the practice and education recommendations. We now have an opportunity to ask questions, and we see a couple questions coming through, so please continue to ask as you see fit. Okay, so there's a couple of questions about the $5,000 grant that I was speaking about. So as I mentioned, the tobacco intervention program has been around since 2007. We partner with organizations every year. Right now we have over 45 sites. So if you apply to be a site, which is an online application, you are eligible for a $5,000 grant, and you can use that $5,000 for implementation activities. It might be applying to a conference that you want to speak about your role in tobacco interventions. It may be attending a course like TEACH or a course on motivational interviewing. So these are just some ideas that you can use to put towards your $5,000 grant. There's another question about pregnancy, and I'm going to ask Jennifer to address this question. This question is asking, based on the pregnancy recommendation, do you recommend using counseling as a first line of treatment before NRT, or is it both at the same time?
So thank you for that question. I would say, and I think a lot of the discussion is that we don't want people to be afraid to recommend nicotine replacement therapy to pregnant women. The evidence still isn't clear, but what we do know is that women are getting nicotine anyway through their exposure to tobacco use. Of course, any first-line treatment is going to be behavioral, and if we can support any client, regardless of their physical condition, if they're pregnant or breastfeeding, or regardless of their health status, if we can support any client with behavioral interventions alone, then that's always going to be the best way to go. However, the evidence does say that the nicotine replacement therapy, based on sort of the complexity of nicotine addiction, nicotine replacement therapy is going to increase your chances of success. So it's not really an easy question. Would I try behavioral interventions first? Yes, I would with any client, recognizing that the effectiveness of behavioral interventions alone is not great. What we need to do is give our clients all of the options, particularly women who are pregnant, give them all of the options and work with them to do what's going to best meet their needs. And we do know that incorporating the nicotine replacement therapy into their treatment and starting with the lowest possible dose or starting with short-acting versus long-acting is going to increase their chances of success. So we want people to use it as the tool it's intended to be in conjunction with the self-help materials, counseling, the other behavioral interventions that you're incorporating. So it's not an easy question to answer, but what I can say is, in most cases, nicotine replacement therapy is going to be indicated to support clients. If a woman can quit on her own without and just with the behavioral counseling, amazing. but most often there's going to be value in having the discussion for sure around incorporating some form of nicotine replacement therapy.
Thank you, Jennifer. I have another question. It says, nurses find it challenging to treat tobacco dependence in a residential care facility setting due to various reasons. Residents don't want to quit. So how do we work with integrating tobacco interventions in this kind of situation where residents just don't want to quit? Jen, can I address that question to you as well?
Sure, no problem. That's another not so easy question. If you're talking about an actual residential facility that's privately owned, group home or boarding home type of facility, then there are some challenges with incorporating smoke-free or incorporating tobacco interventions there. There's not a lot of if it's private spaces, private rooms that they're paying to rent, it is their private residence, and that's when it does become difficult. So depending on the type of facility, if it's a long-term care home, you have a lot more protections under Smoke-Free Ontario Act. If it's a workplace, then smoking can't be in the workplace, so there's some protections there. But as far as providing an intervention for smoking cessation with at-risk or under-resourced people living in a residential facility, there's a couple of things you're going to need to do. First is going to be persistent. Second is try and get organizational buy-in. Partner with your community partners, your public health unit, to identify where free support, free medication, if we're talking about some social determinants of health issues, where counseling and pharmacotherapy are available for free in sort of comfortable environments. This is another one that's not so easy to answer. I would say start looking at use the RNAO best practice guideline as a tool. Start looking at what's happening internally. Do an internal environmental scan. See what kind of organizational buy-in you have. Talk to the residents. Provide free support and pharmacotherapy if it's available. Try and find some champions. It's really going to take a team effort in that kind of sort of residential or group home environment to move ahead. So not another easy question.
Thank you, Jen. Once again, there's quite a few questions, and so I'm going to take one more, and then, as I mentioned before, we will address all of the questions that have been asked, but we will email the group, because we're running out of time. So we will get to all the questions, just not on this webinar. So the last question is, where can I get the application for the RFP? So as I mentioned, it will be available online through our tobacco-free RNAO website. And we can provide the link to this group that's on the call today, so you can apply. There's going to be a letter of intent that is due in mid-July, and that's just a quick email saying that we are interested in applying, and then the actual applications are due in mid-August. I believe it's August 14th. So this is an opportunity for all of you to be involved. So thank you for those questions. And thank you to all of you for joining us today. We appreciate your support and your ongoing engagement. I know there was a lot of stakeholders on the phone today and a lot of panel members. So we thank you for that. Also, I want to let you know that we will be posting the link to the BPG right now. So you can go ahead and access the BPG. We hope that today's webinar will give you a little bit more ease when you go into the guideline, and you'll be able to know exactly what to expect when you review the guideline and understand a little bit of the background of how decisions were made when you read through the discussion of evidence and the recommendations. We also will have an evaluation. We always like to hear from you in terms of how we're doing and how we can improve. So we'll definitely send an evaluation link after the webinar. So thank you once again. Thank you, Jen and Shelly, for all of your help. And this has been great. So I hope everyone has a wonderful day.